You get the...
Okay. Folks are joining. We're recording.
Yeah. Well, welcome. People are popping in. And I know we're running this at a bit of an unusual time at 1 rather than 12. So I think a lot of people signed up so they could get the slides and listen to the recording, because it is at a time when oftentimes people don't have time off. But anyway, we appreciate you coming. We'll just let people continue to pop in since it's just 1 o'clock. But we are very excited to welcome Munira Gunja, right? So, and I'll just chit chat for a little bit while we're getting ready here, but introduce Munira. But so this is Public Health Grand Rounds at MaineHealth. We do offer CMEs for this. So if you're interested in continuing medical education credits, there was a link in the registration. For some reason you weren't able to link onto that, just email Ellen Friedman at ellen.friedman@mainehealth.org. And so we're very excited because of the fact that we have this been dealing with a maternity desert really across the state. We are the most rural state in the country, and we have in many of our rural areas, as I share with Munira, in the last several weeks, that we've had almost half of our hospitals in rural Maine have had to close their labor and delivery units. And so we are looking on the Maine Hospital Association, MaineHealth hospitals, many providers across the state, FQHCs, hospitals, and midwives, and many others, along with the state, Maine DHHS, Maine CDC, MaineCare, are working together with many other organizations too, to try to figure out how do we address these issues. And a lot of this comes down to figuring out how do we transform maternal health care. And one of the places I learned the most about what works in other countries and why so many other developed countries, like I think all other developed countries in the globe, have better outcomes, maternal and infant outcomes than we have, and at much less cost. And one of the major places I learned about this was through the Commonwealth Fund and a couple of studies that they've done in 2000 and 2024. So I'm very honored and delighted to have one of the lead authors on their study with us today, Munira Gunja, who is a MPH. She graduated from Tulane University, which is well known for those of you in public health, as I am, extremely well known for their global public health, particularly. And she has also a degree in international development and a master's of public health and epidemiology. She worked actually at the Assistant Secretary's office at the US DHHS for several years and won some awards there. And then the last about 10 years or so, it's been at the Commonwealth Fund, which is a very prestigious foundation that conducts such studies as they've done with maternal health. So I'm going to pass the baton over to Munira and thank her so much for joining us today. So welcome, Munira. Welcome to Maine virtually. And you're in New Jersey, I believe.
Thank you all. I think I've only been to Maine once. I liked it a lot. My husband went for the lobster rolls. You know how it goes.
Well, you come back, we'll get you another lobster.
Well, thank you all for having me today. I'm really excited to be here. My name is Munira Gunja. I am the senior researcher in the International Health Policy Program at the Commonwealth Fund. I've been at the fund for nearly 10 years. The first 7 years were in the coverage and access program. So it was almost right after the marketplaces opened for Obamacare. So really working on assessing what's going on there. And then in the past 3 years, I've moved over to the international program. So I'm going to share my slides. Hopefully it all works seamlessly. It never does, but we're gonna hope for the best. Can people see my PowerPoint? All right, awesome. Let me do the slideshow. Okay, so for today, what can people see? The topics for discussion.
We are seeing your slide presentation, though not in slideshow mode, we're seeing the, the smaller version of the slides off to the left. And then so I don't know if you've got it on slideshow format.
Let's see. I do. I'm playing with way too many screens right now. Okay, so I'm not going to use slideshow mode. I'm sorry about that, just because I don't know how to work with my screens. Apologies.
That's okay. We can see your slides okay, I think. I mean, I can, so.
All right, so we're just going to do this.
You could probably just hide the format background, the little X on the right-hand side.
Yes.
And then maybe, I don't know, Libby, Libby, if you're more experienced with how she can share that.
Sorry about this, you all. Let me get this back going.
Could you say that one more time? I'm sorry.
Sorry, give me 1 second. I may just not have, because I have so many screens going on, I may just have to.
Open it up again, maybe.
Yeah, and not use.
Okay. Is this the right one? No.
Oh, here we go. All right, I'm gonna do this. Sorry about that, everyone.
Oh,
That's okay. If you wanted to show in slide mode, you might not be able to see us. So, but that's fine.
Yeah, this is fine. We can see it. This is great. Thank you.
Perfect. So for today, my proposed agenda, and I say proposed because really this hour is for you all. So if you need me to pivot, answer questions, please jump in. But I want to give an overview of what the Commonwealth Fund is, so you understand why we conduct this work and kind of just where I'm sitting. And then I'll jump into where the US stands compared to other countries when it comes to its health system. And then I'll dig deeper into maternal health specifically and how the US compares to other countries. And then finally, I'll end it with solutions and what we can do to eliminate really what we consider are avoidable deaths. So the vast majority of maternal deaths are considered avoidable. So that means if you have the right preventative methods, including vaccines, screenings, access to nutritious food and housing, and the right treatment. So that means having access to a doctor and being able to utilize health services, these deaths could have been avoided. So what is the Commonwealth Fund? Well, it is a nonprofit organization based in New York City, and it was established in 1918 by Anna Harkness. Our mission is to promote a high-performing healthcare system that achieves better access, improved quality, and greater efficiency, in particular for society's most vulnerable, including low-income people, the uninsured, and people of color. So we do this by really separating out into a few different teams and then coming together and then collaborating across those teams as well. And so we have a coverage and access team that really tries to understand all the different types of insurance, who is insured, who has comprehensive, affordable coverage, what's going on with the uninsured and insured populations. Then we have a payment and delivery system reform team, which really tries to understand what does workforce look like and how do we really create financial incentives to create more optimal health outcomes for patients. We have a cost containment team, so where is our money going? How do we really improve efficiency with using our money and make sure that every dollar is being used in the best way possible? We have a team that's focused on the Medicare population, a team that's focused on the Medicaid population, and then we have a health equity team that really, even though that they're their own team, they do work across the programs. Finally, we have our international health policy team, which is where I sit, and we really want to understand what other countries are doing to make their systems more functional, efficient, equitable, all the things, and what models can we apply and adapt to the US healthcare system. So to dig a little bit deeper into the international team, we seek to improve people's lives by being the trusted source for international insights that spur change to the US healthcare system. So we do this through a lot of our own internal research, which I lead along with my colleague, Evan Gumas, who may or may not be on this call. We work collaboratively, internally and externally with people all over the place to really try to identify problems and ways to fix those problems. And then we have a whole leadership development program, which is our Harkness Fellowship, where we really bring leaders from other countries to live in the US for a year. They're able to see firsthand US healthcare all the good and bad, and then bring the lessons learned back to their own countries. So the reason I'm even explaining all this to you is because through all of our research, we really have such a huge network of experts. And those experts may be at the state level, federal level, in the US or abroad, and they may be experts on really any health policy related topic. I do work on a ton of health policy topics. My passion area is women's health, which is why I'm so excited to be here today. But if you have a health policy question and it's in Germany, ask us. We may have the right person to direct you to. So just throwing that out there, don't ever hesitate to reach out to us. Okay, so why do we really have an international program at the Commonwealth Fund? Why is it so important? Well, the US is a big outlier when it comes to health spending. We spend a lot of money, a lot of our GDP on healthcare, nearly 17%. And while countries around the world have been spending more and more over time on healthcare, the US is spending way too much. But the problem is, we know that spending a lot of money doesn't always lead to better outcomes. This exhibit is from one of the Commonwealth Fund's biggest reports called Mirror. And in Mirror, we benchmark health system performance in the US against 9 other countries. And what we find is that even though the US spends so much on healthcare, we actually have the lowest health system performance. So something really doesn't add up. And that's where we come in. We really want to understand, well, what are other countries? How are they able to achieve better? How are they able to develop a better health system with less money? And what can we do and in the US to apply these changes and make our system more functional? So there are a lot of reasons why our health system performance is so low. But let's start at the basics. Insurance coverage. We are the only high-income country that doesn't have a universal health system. In all other high-income countries, every resident is guaranteed access to affordable health care at baseline. So you can see in this chart, 100% across countries, everyone has health insurance coverage. If people choose to want to supplement that coverage with private insurance, they absolutely can. In some countries, that's more popular than others. In places like Japan, Norway, and Sweden, no one wants to take up any sort of private insurance. It may not even be an option in those countries. In the US, it's flipped. The majority of people who have health insurance have private health insurance, so either through their employer or through the ACA marketplaces. And then a smaller percentage has health insurance through public programs like Medicare and Medicaid. But that still leaves about 8% of the population uninsured. So already, at baseline, we are leaving Americans behind, people from other countries, right? We already don't give guaranteed access just for people to go to the doctor, just for basic preventative care. And we know this really does have dire consequences for Americans. So when it comes to life expectancy, for example, Americans have the lowest life expectancy compared to people in other high-income countries. In this graph, I know it's really small, I apologize for that. I'm happy to share slides after. We look at what each state in the US looks like when it comes to life expectancy compared to other countries in the OECD. And so we see here that no matter where you live in the US, so in California, for example, which has the highest life expectancy in the US, it's still lower than many high-income countries. This red arrow indicates where Maine is. Maine comes basically in the middle of the US when it comes to life expectancy. And it's a really similar story when it comes to avoidable death. So again, avoidable death is death that could have been avoided in the first place with the right treatment and preventative care. The US has an incredibly high rate of avoidable deaths compared to other high-income countries. And when we look at it by state, again, even the best state in the US, so in this case it's Minnesota. Minnesota has the lowest rate of avoidable deaths in the US, but it's still higher than many other high-income countries. And again, Maine comes out somewhere in the middle. So we have a lot of work to do at the federal level and state level to really figure out how to improve health systems across the board. when it comes to maternal health, we have another crisis. Our maternal death rate is really high. It's 22 deaths per 100,000 live births. That's higher than any other high-income country. In places like Norway, it's 0 maternal deaths. But Black women in the US have a maternal death rate that's nearly 2 times higher than the US average. But we also know that a lot of these deaths, 65% of these deaths happen in the postpartum period. So this exhibit really collects data from 36 states using the Maternal Mortality Review Committee, which assesses why and when each death took place. And so we see that during pregnancy, about a quarter of deaths happen. During the day of delivery, it's 13%. And then 2/3 of the deaths happen from 1 day postpartum to a year postpartum. And it's because of this exhibit that a lot of our work at the Commonwealth Fund that looks at maternal health is really focused on postpartum care, because we know women lack support during this period, but that it actually has really terrible consequences for women. So what are some of the reasons there's so many deaths happening in the postpartum period? Well, one, as you may or may not know, the US is the only high-income country that doesn't have a guaranteed federal paid leave system. Thus far, 13 states plus DC, Maine is included in this list of 13 states, have some form of paid leave policy. I believe Maine's kicks in 2026 next year, but someone on this call may need to verify that for me. But that's still, while these are great steps in the right direction, where you live in America really matters, and that matters to a lot of women who have access to no paid leave because either they live in a state that doesn't provide it or their employer doesn't provide it. And we know this disproportionately affects lower income women and Black women. But we also know the importance of paid leave. Paid leave is an opportunity to take time to bond with your baby, to get your mental health assessed, to really just take care of your own body and make sure that you're able to access services that are necessary to avoid any complications. Another huge thing missing from the postpartum period for women in the US is that we don't provide really easy access to care. So what I mean by that is that in the US, you have your baby, 6 weeks later, you're expected to go to the doctor's office and do your postpartum checkup. Well, that's great if you have the transportation to get there, if you have someone to watch your newborn, if you are in the right mental state to figure out those details of getting in the car and having someone watch your newborn. There are a lot of obstacles to getting there, and it's because of that 40% of women in the US skip that postpartum period, the majority of those women being younger women, women who are uninsured, and women of color. But in other countries, that's just not the case. What happens in other countries is that you have your baby, you go home, and someone always comes to your house to check on you. And the frequency of that happening and the length of that happening may vary. So in some countries, you'll have multiple home visits for up to 3 months. In some countries, you have multiple home visits for up to a year. But those home visits are, for the most part, being made by a midwife or public health nurse. Those home visits are really important because someone comes to your house, someone who the patient generally is able to build a relationship with. That person is able to assess mental and physical health. They're able to assess other social supports, including making sure the woman has access to nutritious food and housing, and there's no domestic violence happening. There's a lot of support happening during that time, and it's a guarantee. And the last area I'll really talk about, which is not only does not only concern postpartum period, but maternal care at large, is our maternal care workforce. We have a real big problem in the US. Our maternal care workforce is small. So what this graph shows is 2 problems. First, our total supply of maternal providers is just small. We don't have enough. You'll see from this graph that we're very near the bottom of having when it comes to looking at how many providers we have. But the second problem in this graph is that you'll see in most countries, the majority of the maternal health workforce is made up of midwives, and a small percentage is made up of OBGYNs. In the US, it's flipped. The majority of the maternal health workforce are OBGYNs, and a small percentage is midwives. So I just want to turn over and give two case examples from the international context. And I chose these two examples because they do a really good job when it comes to providing postpartum support in all the areas that I had mentioned. So in Germany, the maternal death rate is 3.5 deaths per 100,000 live births, and midwives really outnumber OBGYNs. But not only that, midwifery care is considered a legal right in Germany. Every woman has access to a midwife, and the midwifery services are covered fully from prenatal to postnatal care. After a woman has a baby, they really receive comprehensive postpartum support. So that includes up to 36 home visits, 3 months after giving birth, and 58 weeks of paid leave. In the Netherlands, the maternal death rate is 2.8 maternal deaths per 100,000 live births, and the rate of midwives is double that of OBGYNs. And again, midwives are really integrated into the community here and are fully covered. Maternal care is fully covered from prenatal care to postnatal care, and home visits are made by midwives up to 10 days postpartum, and women are given 16 weeks of paid leave. So you'll see there's certainly variation in the type of home visits that are being provided and the frequency, but the point being is that these are being provided at the very least, women have this guarantee of having a home visit, which is incredibly crucial. The reason why I want to point out those two countries, though, because all the countries in the analysis, besides the US, quite frankly, are doing really well when it comes to postpartum support, is because 2 years ago, the Commonwealth Fund partnered with Lemonada Media, and we created a podcast called Uncared For. We now have 2 seasons of Uncared For, and the first season is purely focused on maternal health. So I may be biased, but I don't think I'm actually that biased. It's a great podcast. They do a really, really good job diving into the issues of what's going on with maternal health in this country and how other countries have been able to solve these problems. So one episode is focused on Germany, another episode is focused on the Netherlands. If you are a podcast listener, I really encourage you to listen to these 2 episodes at the very least. It will make you want to get on a plane and go right to these countries, I'm sure of it. But they really support women, and the information I provided is a very high level of what's going on in those countries. All right, so what can the US do to eliminate maternal deaths? There's a lot. The first thing is access. We need to provide universal coverage for all women, invest in primary care, and remove cost barriers so people can get care when they need it in a manner that works for them. This is taken from March of Dimes. In the US, about 16% of women still receive inadequate prenatal care. So that means that they only go visit their doctor for the first time 5 months or later during pregnancy, which means that they're just not getting enough checkups. In Maine, it's a bit lower than the national average at 11%. I also want to throw this in because Maine is the most rural state in America, so this maternal vulnerability index really shows where women are most vulnerable and where policymakers and stakeholders may have to get a bit more creative to ensure there's adequate access to care in these areas. So this chart shows what the uninsured rate looks like by state in the US among women of reproductive age. And in Maine, the uninsured rate among women between the ages of 15 and 44 years is 8.8%. So it's a bit higher than the national average. I wanted to point this out because, well, 1, we should know what the uninsured rate is for this population, but 2, because this is taken from the Commonwealth Fund Women's Health Scorecard. So what the Commonwealth Fund does every year is create a state scorecard that looks at where each state ranks on many different health system measures in a given year. Then we also have another product that is solely focused on women's health. So it's all about what does women's health look like in each state across all these measures, and where does your state rank? The link to the scorecard is at the bottom of the slide, but if you're interested in understanding different state policies when it comes to women's health, you should really check out our Women's Health Scorecard. It's a really, really valuable resource. The next area I'll talk about is workforce capacity. We need to strengthen our maternal care workforce with an emphasis on midwifery and community-based providers. The WHO recommends midwives as first-line care for all low-risk pregnancies. They say that high-income countries with the lowest intervention rates, best outcomes, and lowest cost have integrated midwifery-led care. I really like this exhibit, and full disclosure, it is 10 years old. So sure, maybe a little outdated, but the story is still the same. So what this shows is that the U.S. maternity care workforce is upside down relative to patient needs. So we have a lot of OBGYNs who are trained to do high-risk pregnancies and only a small percentage of providers who are trained to do normal pregnancies. But the reality is the vast majority of pregnancies are healthy, normal pregnancies. Only a small percentage are high-risk pregnancies. So in order to create efficiency and improve health outcomes, maybe it would make sense to have a workforce that actually represents the population it's serving. Other countries really do this much better than we do at the US, but the US, we really have flipped the system. In fact, only 11% of births in the US are attended by a midwife, and only 2% of births occur outside of hospital settings. Most of the US midwifery workforce reports working exclusively in hospital settings. And there is a ton of information. So the reason why midwives are so important is not only to help increase our maternal care workforce shortage crisis, but it's also because there's so much evidence that shows how effective midwifery care is. Midwives can perform 80% of maternal care services, and they're able to reduce maternal mortality deaths and neonatal deaths by 40%. These are huge numbers. So really integrating them into the workforce is really critical. And when it comes to our maternal care workforce shortage crisis, sorry, let's go back to this for a second, we have a real big problem. Half of the counties in the US don't even have one single OBGYN. We need about 8,000 more OBGYNs to get us out of crisis mode. And by 2050, this number is expected to increase by 22,000. So if we don't take action now, we're going to have a worse problem, but we have a pretty bad problem now. The next area is comprehensive postpartum support. So we need to make sure that everyone, including those on Medicaid, have health coverage for a full year postpartum. I'm happy to say that most states at this point have adopted extending Medicaid to 12 months postpartum. Before, it was only 3 months postpartum, which we know is absolutely not enough time. But we also know that there are threats to the Medicaid program, and this can have really negative consequences, especially in a place like Maine, where 38% of births are covered by Medicaid. A cut to Medicaid would prevent mothers from obtaining the care they need. A cut to Medicaid is not going to help our maternal health crisis. And then the last area I'll talk about is inequities. We need to address racial inequities and implicit biases in care delivery and center equity as a core principle in any future maternal health policy changes. At the Commonwealth Fund, our health equity team does a lot of work in this space. We want to understand how discrimination and biases play out in healthcare among patients, but also among providers. And we know time and time again, providers are telling us there's a lot of discrimination that takes place. One survey we recently conducted found that half of all healthcare workers say racism against patients is a major problem or crisis. And in that same study, we found that employees of a facility that serves mostly Black or Latino patients reported witnessing discrimination at higher rates than employees at facilities who don't primarily serve those populations. One provider said, "We treat our patients to recognize the signs and symptoms of stroke, but why can't we pre-treat our own internal staff on the signs and symptoms of discrimination?" So we know this is still a really big problem and cannot be ignored as we try to think about ways to address maternal health. I'll quickly say here that all of the solutions are very effective, but really trying to make sure that they are incorporated into community-based models is going to be the most effective way of getting at this problem. Community-based models are proven to really be great resources to the community, especially underserved areas. There are ways for women to build trust with their providers and to get care from the prenatal to postnatal period. There are only 415 freestanding birthing centers in the US, and fewer than 5% of those are led by Black, Indigenous, or other people of color. You also know it's really hard for these centers to sustain themselves without federal funding. So for any policymakers in the audience, for anyone who knows a policymaker, try to encourage them to really push for federal funding that's sustainable so that these birthing centers can actually serve the populations they strive to serve. I'm not going to go into this slide here because I already really explained everything, but I just want to show this because if you are really interested in understanding how midwives can be integrated into the community, on the right side of this chart are some really great resources for you to dig into. And my last slide here are even more resources. So at the Commonwealth Fund, we cover all maternal health from the state to national, international level, and really enjoy doing the work, but we have a long ways to go. I'm going to end there and I'm very happy to take questions.
Wow, thank you so much. If you look in the Q&A, there are several questions. I also just wanted to start out, Munira, by asking if you could clarify, when you're talking about midwives, I believe in the Commonwealth studies, there is the definition of, certified professional midwives versus nurse midwives. And then I think there's a third category, and that in a lot of these other countries, they're generally mostly nurse midwives, but I think you use the terminology. Can you just define what you mean by midwife?
Yeah. So in the U.S., there are different types of midwives, and really the scope of the definitions vary in terms of scope of work. So most certified midwives who work in hospital settings can do preventative care as well as maternal care. In other countries, I would have to double check on this, but I don't think that that the definition. I think if you're a midwife, you're a midwife, to say it bluntly. Midwives are part of the maternal health care workforce. They're integrated and very well known for their care. And they are paid for by hospitals or other independent health clinics. So they are able to take on the work they're supposed to take on without all these restrictions and administrative hurdles to getting their certification.
Great. Thank you. So do you want to take a look at the Q&A button? So I can see that Janet Lewin's got a question. Oh, she's comments about her postpartum visit was quite brief.
Well, I did quickly skim your statement and your thoughts on that. I agree. My postpartum visit was not really much. I will say that when I talk about maternal health to reporters, the question I get across the board is, what about maternal mental health? That is the one question we just don't have enough information on. That postpartum checkup could and should be an opportunity to get that. But I don't know about you all, but I remember when I was asked those questions, A, my postpartum depression didn't kick in yet, and B, I wasn't honest. And why should I be? I didn't trust my provider. What did it mean? Were they going to take my baby away? You don't know. Women just don't know what the consequences are of being truthful. So we have a lot of work to do to improve that experience for women.
Yeah, good point. And I think I had shared with you too that when we did the HRSA Our Moms evaluation or assessment the first year of the grant, 3 years ago or so, what we found out to our surprise was that maternal mental health in rural Maine arose to the top in terms of the health issues, the specific health issues. And we thought originally it would probably be obesity, diabetes, and hypertension, but it was by far maternal mental health. So, and I think that's because we have an epidemic of anxiety and depression amongst young people, and they're getting pregnant, and pregnancy exacerbates a lot of that pre-existing issues. So, yeah, so I agree with the postpartum visit, at least the one I had years ago. My kids are in their 20s, but it was very much cut and dried, and I agree. I would not have answered probably honestly about any anxiety or depression I might have had. So it's a good point.
Also,
So that,
I'm sorry.
no, go ahead. No, go ahead.
I was just going to say, when it comes to international comparative analysis, there's just no data. We just don't know. We do know that deaths that do occur in other countries, the most common reason is suicide. So we know it's a huge problem, but it's an even bigger problem in the US.
And I think in your studies too, it really, as I recall, some of the language that you used in the studies was around, or at least I had this vision of that there's really emphasis on a relationship that begins with a midwife, a doula, community health worker, et cetera, maybe a team of 2 or so people that starts oftentimes with a home visit early in pregnancy, and really builds a trusting relationship. What I think about if we're working with, trying to address health issues, medical issues, but also emotional health, mental health issues, and social drivers of health, you can't do that unless you've got that trusting relationship. And it seems like you're describing a workforce that is really can do that very well. But anyway, Erica's got a question here too about home visiting, policy implementation, utilization of home visiting. We have a number of home visiting programs in Maine, but I think she's just wondering if there's any, did you see, and I think I remember in this, at least in your studies, the home visiting was done by midwives and doulas. Like it wasn't a separate program over here necessarily in other countries.
Yeah, as far as I know, no one's ever raised stigma as a concern when it comes to home visits. It is so part of routine maternal care in other countries, whereas I think it's just beginning here. So I even know when I recently moved to New Jersey implemented, sorry, I should not say the state of New Jersey, my county implemented a midwifery home visit program. So I think you get a midwife 3 times postpartum.
Wow.
We even don't know about it. It's still so new. So I think that stigma that exists here hopefully will die down over time, but in other countries, it's routine care.
Wow. Great. Yeah, and then moving down, and I think we've also got questions in the chat too. Some are in the Q&A section, but we also have some in the.
Yes, I can. I mean, if you all are willing to share the slides, I'm happy to share them.
Oh, thank you. So you want to, Ellen, can you share them by email to everybody who registered? Is that
Sure, I can share them. And I see you toggling over to the chat because there's some comments there, Dora, in the chat. Great.
Sarah Hansett mentions that state of Maine has maternal child health, public health nurses that do home visits. Yeah, and there's healthy family health. Oh my gosh, Kelly, remind me. Families first, though. Healthy families.
I think you mean Maine Families Home Visiting Program. Yeah, it's a parenting support.
Yeah, but they are separate from the prenatal, postpartum care, labor and delivery care. I mean, whereas I think in other countries, what I remember from the Commonwealth studies is that it's one system. So you get a midwife and a doula, and they come visit you at home after your pregnancy test is positive, and they follow you all the way along, and they do the delivery if you have a low risk pregnancy. But if you become higher risk, you go to a family physician who can do C-sections or not, or an OBGYN. But the default on a healthy person with a healthy pregnancy is you are seen by the midwife and doula throughout. And they do home visits. So it's not we have this separate home visiting program that's separate from the health care that you're receiving, the maternal care you're seeing or having. So, so I see some other things here, other comments. There's recently been a cut for visiting public health nurses in New York and Cumberland counties. Yeah, we've been hearing about that recently. I haven't heard verification of it, but so a state like Maine, so you've got several great recommendations that come out of the studies, the way I'm reading it. So, in the way I'm seeing your slides too. So some of it has to do with statewide policies around, postpartum time off, the family medical leave and the like, postpartum leave. And then also health insurance coverage, which we do have. Medicaid in Maine does cover up to a year postpartum. So that's good. And then, but I also saw, in your studies, and you've mentioned this too, about the diversification of the workforce. We do have just received, the state of Maine just received the TMA grant, the CMS Transforming Maternal Health Grant, which I think does help to strive to do that. So I think one thing they're looking at is they're working with doulas in the state to try to figure out the certification and reimbursement. And then also we're, our moms, as well as the state and others, were looking at how do we don't have any nurse midwife education programs in northern New England. We also don't have a family physician OB fellowship anywhere in northern New England. So we've actually been in contact with Vermont and New Hampshire as well, realizing we have similar challenges. And that also goes for other professions as well. So we don't have any OB rural training opportunities as well, or we're starting to emerge, but for medical students. So anyway, but Kelly Bowden has been in maternal child health, in maternal health, particularly in Maine, for many, many years. So it's great to see you, Kelly. Thank you. So she's much more of an expert on this than I am. So so Kelly, I'm sure you must have some questions too.
Yeah, thank you. I'm curious about, as us being such a rural state, and we do have one model in the state that just for general health, they're doing, they have a mobile unit where they're doing health checkups, and then thinking about telehealth. And what have you learned anything about either of those two options from other countries?
Yeah, those are really, really good points. Not maternal health specifically, but we know in other areas of care how effective mobile units are in reaching these harder to reach populations. And so in a state like Maine, that actually makes a lot of sense. So it's really great that that's happening. In terms of telehealth, I don't know specifically how much patients are utilizing telehealth for maternal care, only because their access problem isn't as daunting as ours is. So when I was pregnant with my daughter, I was living in New York, and I remember having trouble finding an OB in New York City that was taking new patients, and I remember panicking. And that's just not as prevalent elsewhere. And so because of that, I don't know if there's a need to utilize telehealth as much as it may be the case here. Certainly there are going to be rural parts of countries that are going to have access, but I just don't think at large it's a big problem. We do ask in other areas of care just using our Commonwealth Fund surveys. So in the Commonwealth Fund, we survey respondents every few years in the US and 9 other countries on their access and affordability of care, and how they're able to access and afford their health care. And telehealth is part of that series. And of course, because of COVID, we've seen a higher uptake with telehealth, but it would be a good question to think about maternal care too. And I say that because we are currently developing our next survey on the general population. And I know there's a lot of interest in adding more questions that are specifically on maternal health. So maybe thinking about how to ask about maternal health in terms of telehealth be a really valuable question. So thank you for that.
Good point. And I should just mention too that while, I've been sort of focused some of my questions on rural maternity because we are the most rural state in the country, but also because I'm the PI on the HRSA funded Our Moms grant. But we do have real cultural and health disparities around our racial and ethnic minorities. Some in rural Maine too. We have 5 federally recognized tribes in Maine, but also in our more urban areas in southern Maine and Portland area, we have a number of new Mainers, immigrants from the last several years. And so one question about that is, I remember seeing in your studies about the doulas and community health workers working alongside with nurse midwives to do home visits and the like. And so I just wondered, doulas versus home community health workers, and are they, kind of interchangeable if they come from the same community that they're serving? Because I think that's one way we've been trying to address health disparities is to have community health workers who are from those communities. But I was thinking, well, doulas could probably do the same thing from that community. But I don't know. Do you have any insights on that?
So I wouldn't say they're interchangeable just because I think the scope of work for a doula is very different than the scope for a community health worker. I mean, a doula is not someone who can provide medical advice, but they can be an advocate and they can be a voice. And so I think they're both incredibly important to have, but the bigger, for sure, without a doubt, I mean, creating that trust is just so necessary. But one of the bigger issues when it comes to all these sorts of health workers is that they're not accessible. So you may have health insurance, but your health insurance doesn't cover it. And so what happens is that you have to either pay out of pocket, which can be very expensive, or forego that type of care. Or you are a doula or community health worker and you're going in it with the right intent, but reimbursement is so low that how can you possibly make a living only serving this population? That will be really, really hard. And so we disincentivize people from wanting to become part of this sort of workforce. And so unless we create these incentives to really make sure that people are people who want to do the good work are able to actually do that work, we're going to always run into this problem of much higher demand than supply.
Great, thank you. Holly, hey.
Hi, good afternoon. I don't know if anyone on here is from MaineCare, but I know MaineCare is going to be doing a doula pilot because we have had some conversations with them where navigators or CHWs could be dual trained as a doula. More to come on that, but that's just another concept.
Right. Thank you, Holly. And that's part of the TMA grant, right? Working on it. That's great. And then Katie's got a comment or question. Function as a type of CHW. Yeah, it does seem like there's a Venn diagram with some overlap, right? Even the distinctive duties of roles and responsibilities.
Oh, yes, sorry. I didn't mean there's no overlap. Absolutely not. I mean, of course, there's certainly overlap between the two roles.
And we don't have many birthing centers. Kelly, do we have like 3 or 4? They're mostly they're not. There's not a licensure program for them right now in Maine. And the challenge has been is we are so rural that I think they have to be within a half an hour or should be by standards of a labor and delivery hospital. So our birth numbers in our labor and delivery hospitals are quite low. So there is a concern that if you put birthing centers to, close to a hospital, they have to be close to a hospital that has a labor and delivery unit, at least within a half an hour, as I understand it, or something like that. But then they can also take away so many births that the volume isn't sufficient for that hospital to continue that labor and delivery. So they tend to be mostly in the more urban areas of Maine, which I think is fine. But I don't know how sustainable they've been able to be, because even those numbers, I mean, they're not. It's a small state. We only have under 1.4 million people in the entire state, and we're geographically larger than the rest of New England combined. So we're really spread out too. So. But yeah, I know, Kelly, do you have any other observations about that?
Just that there's 5 freestanding birth centers. There was one that was certified by it's the American Association of Birth Centers, and they let their certification lapse for unknown reasons. So there is still a freestanding birth center in Bridgeton, which is really pretty rural, and the next closest hospital would be Stevens in Norway, which is 30 to 40 minutes, depending on weather and road conditions. So there have been around 24 certified professional midwives, so the non-nurse midwives practicing in the state and doing home births. Our home birth numbers increased over during the pandemic when there were restrictions on hospitals and visiting. And so I think out of our roughly 12,000 births a year, about 300 of them are planned home births.
And that used to be about 100 only like 15 years ago or so. So it's gone up,
Yeah.
small numbers, but gone up quite a bit. And I think anecdotally, I think we've also heard that they've gone up in part because as the rural labor and delivery hospitals close the labor and delivery units, I mean, women just can't drive an hour or so each way for prenatal visits, labor and delivery, postpartum visits. So, and some of them prefer to, be home, do a home delivery, but it is, it's a challenge, anyway, when they're having home deliveries and they're quite far away from a labor and delivery hospital unit, because if something goes wrong, if they go to the local hospital, which we have heard stories where that's happened, you really, I mean, there is nobody, very often, there's nobody in those hospitals who can do, for instance, an emergency C-section. So they just have to, put them in an ambulance and get them to someplace close, the next place, which may be an hour or so away. So, well, is there any data on distance travel for delivery? Yeah, I know in Maine, we believe it's about, in rural Maine, the average driving distance is about an hour. It was 45 minutes, but that was before some of the most recent hospitals closed the labor delivery unit. So we believe it's about an hour on average for women in rural Maine to drive for prenatal care and postpartum and labor and delivery, which if you think about it, and most of them, about 60% of them have Medicaid. So, we're talking about low income women with in rural Maine, bumpy, windy roads with right now a lot of frosties and potholes and ice and snow. So it's a real challenge for people to get to care.
Yeah, and I don't know about on the international side. It's a really interesting question. I fear, though, looking at even if that data did exist, if it's at a federal level, it may not be very telling, because what we really want to understand is what does it look like in these more rural areas of the country. And so I don't know if that sort of data is out there, but certainly worth it for me to go to dig and try to see.
And I think that my fuzzy recall, I read the studies last summer, so in early fall, but I think one of the points of your studies have shown that in a lot of the other developed countries like Canada, New Zealand, Australia, and Europe, they've not closed labor and delivery in rural areas because they've been able to diversify their workforce. And I think that's part of the point of the TMOT grant is diversifying the workforce, meaning let's have a lot more midwives and they be the default provider, and then and family physicians who are trained up to do C-sections or deliveries for those who are higher risk. And then OBs are really reserved in regional hospitals for for higher risk patients, is my recall. So there's just like the triangle you used, it's flipping the triangle around.
And home births are more common elsewhere, but I also want to emphasize that the U.S. population has the highest rate of chronic conditions compared to people in other countries. So it's not only that that other countries are providing better support system when it comes to maternal health, but they're making sure that people can be healthier going into pregnancy. And so it shouldn't be a surprise that there may be more healthy, normal, lower risk pregnancies happening than in the US when people are already being plagued by all these other things by the time they get pregnant. So without proper social support, but also health insurance coverage, of course, we're going to continue to leave women behind by the time they get pregnant.
And that is an absolutely excellent point. So thank you for saying that, because I've heard that from some of our OBGYNs when we talk about lower risk pregnancy, people with lower risk pregnancies being cared for in rural areas by nurse midwives and other midwives and family physicians. And they've said, our population's gotten a lot sicker in the last 20 years. Our rates of obesity, diabetes, hypertension, much higher than in other countries, to your point. So, and those chronic diseases especially impact pregnancy. So it leaves us at a little bit of a conundrum if the lower risk pregnancies are much fewer than they used to be. But I think working together with many others, we'll try to figure it out, including from the data from your great studies. Any other questions? We've had some information that's been posted in the Q&A in the chat, and it's been very helpful. Thank you to several of you who have put some of the Alexa Baumgardner, thank you so much for your post. And yes, actually, Munira, if you are actually wanted to be inspired, what's the name of the story about Martha Ballard from Augusta Gardner, Maine, was called The Midwife's Tale.
Well, The Frozen River is the novel that's out now. But yes, The Midwife's Tale was her diaries. But the Frozen River is a good one.
Yeah,
it's a good
The
read.
Midwife's Tale was actually her diary, the transcript. Right. He was from she was a midwife in the 1800s in Maine, in rural Maine, and kept meticulous diary. And if you've got young children, so you probably don't have a lot of time to read, but there is a PBS.
My year, so I'm reading all the reading.
Good, but it's a fabulous book. And she and I think she was into the 1800s, Ellen. I think
17. Yeah, well, I think it was started then, but she was up in the Androscoggin area. Yeah.
But anyway, it was a while ago. But the PBS did a great series on her. I keep looking at Kelly because I know she's been around like I have for a little while, but a couple of years. Was that called also The Midwife's Tale? And it was a fabulous move. I can't remember if it was a series or a movie, but if you've not seen it, I think you can get it off in PBS. And it's wonderful. And it comes from her diary. The Midwife's Tale, the original diary, is a little bit dense to read because it's a transcript from her diary. And then The Frozen River is the novel based on it, but it is a novel. So, and if you go to Augusta Gardner Hollowell, there are a lot of Ballards still living, and they're descendants. Many of them are descendants from her because she had like 9 kids or something herself. But anyway, so if you want to get inspired by a rural Maine midwife, Munira, that's yeah. Oh, thank you, Ellen, for putting that in. So thank you. Well, thank you so much. We really appreciate your time. I know you're very busy at the Commonwealth Fund. We are very honored and excited that you would spend time with us and conveying some of your expertise, your knowledge from being one of the lead authors on these tremendous studies. And I think Ellen put the links to the studies in earlier on. They are great studies to read. They're easy to read, especially the executive summaries, but the rest of them are too. So thank you very much. And next time you're in Maine, let me know, because you and your husband and your kids definitely take you guys out for lobster or whatever you are wanting. So we'll give you the tour. So let me know.
I will. Thank you so much. Summer is coming, so.
Yes.
It was really great speaking with everyone today. Thank you for taking the time.
Thank you. Thanks, everybody. Thank you. Take care. Bye-bye.
Take care. Bye-bye. Thank you.